Welcome to Let's Talk Humanitarian, Parlons Humanitaire, enriching conversations with humanitarian workers and humanitarian leaders to open eyes, heart, and mind. This is a program by KALU Institute, your online center of humanitarian studies, where humanitarians train humanitarians. My name is Amélie Yang-Guifest, and I'm so delighted to be your host today for this conversation with Jorge Castilla from World Health Organization. Hi, Jorge. Thank you for being with us today.
Hi, Amélie. So happy to see you.
Jorge, before we dive into our topic and we listen to you to tell us more about public health, about emergencies, about your commitment to a healthier world, I would like to introduce you a little, because you have such a vast experience, more than 25 years. I think we can even go up to 30 years of medical humanitarian assistance with NGOs, with donors, with UN, with ministries of health. You've started as a general physician in a Colombian rural hospital. You are Colombian?
Yep.
Yeah. Then you were district health director, regional director of epidemiology, and with the Ministry of Health in Colombia. That's where you started your career. Then you went to Sudan as project coordinator, and you have worked on more than 8 humanitarian projects in that country. You worked then on a sleeping sickness program in Uganda. Also, you published many publications on that topic. You've been country manager for humanitarian medical programs in Uganda, Zaire. You took care of the reception of arriving refugees from Rwanda, Zairean, Ugandan, and Sudanese refugees. You handled epidemics of cholera, meningitis, and measles. You were the country manager also for medical programs in Mozambique. So many countries. Then regional medical coordinator, that's where we met, you with ECHO, so the humanitarian aid department of the European Union. You've been in West Africa with them during 4 years, conflict, post-conflict, refugee, epidemic, and nutritional projects in 17 countries. You've been also the focal point for ECHO for malaria and epidemics. And then you joined WHO after ECHO. Okay, and how many years in WHO?
So it's curious because let me begin already to tell you a bit. I feel I'm very fortunate for 2 reasons. Number one, my life has taken me to the key events of the evolution of the humanitarian world, and it has been a luxury to be there by chance, by pure chance. The second is that I have been able to see emergencies from the perspective of a government, an NGO, a donor, and a UN organization. So it has been a learning trip, and I like to learn, so I'm delighted. And for WHO, I have been there twice, and for ECHO, the same. So and it's good. You don't need to be only with one organization, because if the idea is to help people, there are many ways to help the people. So initial work with WHO was at the regional level, in charge of refugee and displacement program. And in this contract that is separated from the other one for many years, it has evolved to the last 5 years, but currently I'm working on protracted crises that last a very long time, which is also a super interesting area to work. And with ECHO, it was the same. I had one first experience with ECHO, and it was really about the region, which was West Africa. And the second experience with ECHO was really worldwide, because ECHO decided to have 6 regional offices, each regional office with a regional doctor, but to ensure coherence and consistency, to have a global overview. So that's it.
Amazing. And I love how you mentioned this journey of humanitarian aid, this trip in a very changing, not only the context, but the humanitarian aid has evolved a lot. So could you tell us what have you observed in this almost 30 years in the domain of public health? What
Okay.
are the big trends that you could share with us?
More than public health, I would say it's a bit about the international system. When I work my first mission, that was 88 in northern Sudan, but afterwards 89 in the southern part of the country, it was the idea that there was really no system. So when there was an emergency, the best that you can do is to have a lead organization. So there will be one organization among the UN agencies that will take the lead. And for the specific case of Operation Lifeline Sudan 2, it was UNICEF, who was in a particular moment of its own life because they had just signed the Convention of the Rights of the Children, and therefore that changed totally their dynamic because they went from one organization that was non-mandate to a mandated one in which the child becomes the priority, right? Then a second moment was the Rwanda genocide. I must confess that I really didn't notice it for a long time because I was so focused on what I was doing in Mozambique that the external world disappeared. You know, it's like a dream.
Yeah.
You're so much into your, but suddenly I saw in the television the bodies coming down from the river outside the country, and I was like in shock, in total shock. And that I observed there a big change because as many of the Rwandan refugees went to DRC, that was called Zaire at the time. This is why you say Zaire, but in fact the name has changed. There was hundreds of thousands of people and hundreds of NGOs trying to manage the guilt of not having been able to react or not having reacted to the genocide. So you have a lot of people with goodwill and with very little knowledge. So they did not do a good work, even if their intentions was the best. And the consequences of that was two things. There's first standards.
Yeah.
So there are standards. If you want to do something, you need to have quality. And the second element was all the training programs on humanitarian aid. That does not existed before.
Yeah.
People like me that went to humanitarian aid were like abandoning society because it was not a profession and it had no future. It was like becoming a nun, you know. And since 1994, it becomes a profession because there are studies and all these type of things. Then I witnessed the birth of ECHO. So I was in WHO. I was in MSF when we had the first negotiations with ECHO, the first director, etc. So it's very funny to remember that time. I also saw as the product of the confusion. So another confusion, the response to the 2004, 2005 tsunami was that people that died in the first 72 hours. So people that arrived to help arrived when there was nobody to save, but they were there. And somehow the help created the chaos because everybody was feeling obliged to do things, right? People arrived there and they created a lot of confusion. The thing to manage was the chaos of so many people. So the humanitarian reform appeared with the clusters and the humanitarian coordinators and the humanitarian funding. Then I was the health cluster coordinator in Haiti when there was this big earthquake. And there was another shift on the humanitarian system with subgroups, with accountability, with other elements. So I think I've seen it all. And just by chance,
Yeah.
I mean, I really didn't plan to be as health operations director of MSF at that time. I really didn't plan to be health clustering, and it just happened.
It's fascinating, and at the same time, it gives me a very positive insight that, I mean, we are learning our lessons somehow. I mean, still we still mess up, and there are still many things to improve always. But what I hear from the big mistakes and the big omissions, the moments where we have failed our mandate of saving and protecting lives, we have learned the lesson. I mean, we've been able to move forward. So thank you for sharing that, Jorge. Can you tell us nowadays what is your exact role?
Okay, so while I tell you this, I will also give you a compact description of what WHO does, because in fact, in spite that WHO has been there for a long time, the overall aim of WHO, which is health, not the absence of disease, etc., is not very practical. And we have now a very practical plan. WHO does three things. It helps the vulnerable, it keeps the world safe, and it improves health. And that translates on helping the vulnerable in practice to extend universal coverage so people have access to health. Keeping the world safe is about preventing, preparing, and responding to emergencies. And among that, what we are doing now for COVID and Ebola and so many things. And improving health is not really about health services. It's about the health determinants, about the nutrition. It's about the mental health. It's about the environment. It's about these type of things. So these are the three areas where WHO works, and I work in emergency. So as emergencies has the prevention, the preparedness, and the response, I work in the response. And there are two very different types of response. There is the acute response to a cyclone. You arrive, you do, and you leave, right? That is an acute response. But there is the response that lasts long time. So for example, if there is a conflict in the Sahel and it touches a new country like Burkina Faso, the mathematics will tell you that the probabilities is that it would last maybe more, maybe less, but a mean of 17 years. And that's a very long time. And if you respond this as an acute response, number one, it's going to be very expensive. Number two, you're not going to be able to fund it. But number three, you're going to destruct a lot of local capacities. So you have to approach it in a different way. And I'm working on that different way, an approach of protracted crisis that delivers services, but builds as much as possible on the pillars of the local health system.
Okay, so I understand that this new way, this new strategy is really much of building on the local system, no?
Yeah, you must somehow you must go by different steps, because the first thing that you need is you need people to survive. So you might do things that are harmful because there is a categorical imperative of saving people, right? It's like with cancer, you know that you might need to apply the medicine, but you will need to have secondary effects, but you accept them because it's worthy, because there is a categorical imperative, right? So that is kind of the first one. The second element is, while you do that, try to avoid things that will be harmful for the future and that will make very difficult the recovery. For example, if there is a system for delivery of supplies, try not to bring everything in a parallel system that will destroy the existing system. And the third thing is try to make your emergency response in such a way that it will build a good future, provided that it does not go against the first imperative of saving people now.
Okay, so thank you for sharing that. So does it mean that when you are working in emergency, of course, the first objective here is saving lives, but you think about saving lives already integrating how is going to the recovery to be, and how does it link to the development programs in place, or the development strategy, or the national health strategy?
Yeah, in particular, if you know that the probabilities is that this lasts long. So in general, conflicts are very long. I think that the only conflict I remember that has been very short was 2008 in Georgia, South Ossetia. It was very, very short, but otherwise they all last 30 years.
Yeah.
And they produce refugees, and refugees remain as refugees for 30 years. So in those occasions, it is really important to build from the beginning a response that is built on local capacities. And when you are very effective, particularly if you are very effective for a long time, you will, with no intention, you will be destroying initiatives that were there and you never saw because you were blind to them, because you were so busy, right?
So what's your advice here? That's so important what you're mentioning here. You know, our blindness. No, so how do you put the specs of checking? What is your advice? At which moment? I mean, you go to the field. You're in an emergency. What do you do? Who do you ask questions to? How do you do?
So I would say that for the priorities of the context, there are so many things to do that you are a bit lost among the, so you kind of see what are the three main elements and you try to address them. And only when they come a bit down, you can enlarge your view to get more and more and more. But it depends on being able to control. For example, if it's a flood and there is cholera and malaria, you have to solve cholera and malaria first before thinking on nutrition and so on. But the thing is that once you identify one area to work, try to explore what can be done with the local resources and capacities before planning what you're going to bring. So it should not be an analysis of these are the needs and this is what I need to do. There should be an intermediate step that says these are the needs, these are the potential local capacities, and this is the gap between the two, so that you deliver as much as possible through this. Let me tell you a story that is incredibly typical, but really sad. There was a number of refugees that went from Uganda to DRC Zaire at that time. A project was started in order to deliver health to those refugees, right? And because we were so good and we have learned so much, really, the service was really good, and the health status became a bit better than that in the surrounding population. So the surrounding population became very jealous, right? Yeah. So in order to be able to help them, the services in the camp were open to the surrounding population, so they can go to the camp and they can receive services. As a result, all the previous private providers of health that were in the village could not survive, because even if the service was supposed to be free, for example, there were payments under the table, whereas in the refugee camps, it was high quality and free. And then the political situation that created those refugees was solved, and the refugees returned to their area. And therefore, our assistance stopped. And there was a village that had no more resources for health of any type. Question, could this have been done better? Could the health of the refugees be subcontracted to the existing capacities in the town? You know, this is what you say afterwards, but now it's too late. But it's an example that, for me, I remember it very strongly, and each step seems so useful, and at the end, there is a problem that you created unwillingly.
So what I'm hearing, and thank you, Jorge, for this honesty and sharing this story, because it is really much of being able also to do this exercise of lessons learned. And that's really needed and important, because now after this story, next scenario, you have brought the question, and all of your team and all the people who've worked with you. So that's so important. And at the same time, I hear, this issue that has been overlooked, that was not thought about. And I'm hearing an issue that I remember maybe 20 years back. We were working on the refugee camps and just providing everything to refugees, high quality. And also we were not talking about, we didn't have so many settings, and we didn't have the crisis we're having in Europe also, etc. So there was funding, and there was these camps and everything. We were working on that. And then the host population was totally forgotten. And we were creating a difference, a huge difference between what was happening in the refugee camp and the local population. And that's what led actually that systematically now we have a refugee situation or internally displaced situation. We look at the local population. So by one side, I also hear in your story how immediately you had this, reaction to say, hey, let's not forget the host population. They have challenges in terms of health access, and we want also to create this integration of the refugee, and that they don't see that because also a refugee camp is always a threat on natural resources and the local environment. So
yeah, but you see how our choices on integration backfire. So this is where I am working now. How can we do better?
Yeah. It's important to continue the reflection, and what I'm hearing, never think that we have seen it. We have seen the problem by all angles. And I guess, in this kind of situation, would you say, Jorge, that would we involve the communities more effectively in terms of hearing their voices and listening to their suggestions or their issues. Do you think that that would have helped?
Yes and no, because in fact, I remember my first 3 years of this type of work. I always work with relatively small populations, so less than 10,000. So even if I didn't knew everybody certainly knew me because I was in bicycle in the middle of the town, right?
Wow.
And I knew enough people to find myself comfortable and to feel I was part of the neighborhood and part of the things. But then you go to places where there have been hundreds of thousands of deaths and millions, and then you can talk with people, but is it representative? If you talk with a man, is he representing the family, the elderly, the women, and the children? So it is a nice purpose. It's not so easy to do, and if you're going to do it, it needs a methodology. It needs a random approach to population in order that whatever you do is representative, right? It is not easy. I hear you, but when you are with big populations, and these days there are always big populations.
Yeah.
With how many people, how many years do you have? So how many hours do you have? It is a good intention.
It's challenging. Yes. So what I'm hearing, let's hold this intention and let's be practical. Yeah. Because the objective is saving lives.
Yeah.
Yeah, definitely. Thank you so much, Jorge, for these precious insights. We've been blessed to, I've been blessed to interview you a few weeks back while you were in Guinea, dealing with Ebola and COVID situation. So we're going to listen to you now. And after, I have 2 more questions for you.
Sure.
Thank you. We saw you and it was so interesting, and to hear you from the field and to see you in the field environment, the typical guest house but then you were waiting for the test of the COVID. So what happened? Can you update us on how you're feeling and what happened?
And the test was positive, so I had COVID. And therefore, I had to self-isolate. But because my behavior is really very healthy regarding transmission, I did not transmit the disease to anybody. It means that the disease died with me, and I did not contribute to its expansion. And to this, I essentially, my organization, WHO, rented an apartment that I paid, but it was a rental for me alone. And I could ask my friends to bring things from the market, and I was there 10 days. And I worked from there with the caveat that, number one, this is a kind of a bingo. You really don't know what's going to happen. You have like a 2% possibility at my age that it goes really bad, and it didn't. But still, I was kept busy working, but I couldn't work for many hours because after 2-3 hours, I was exhausted, right? So, and finally, I got out from the isolation. I finished my mission. I produced the strategic readiness response plan, and it's already in the you can find it in the Humanitarian Response Info. It's in French and English. It comes with the strategic part. It comes with the operational part.
Wow.
So it's all.
So what's the name of the document? So we go for it.
The Strategic Readiness and Response Plan for Ebola in Guinea, and it comes also with a second document that is the operational guidance. And there is an English version and a French version. And the idea of this is to provide guidance to all those that work there so that the work is coherent and consistency across borders and across organizations. So we work together all in the same effort with the same key performance indicators. You can add more, but at least we have a commonality of approach.
Fantastic. That's a true humanitarian worker, with COVID, isolated in a country that is not yours, and but doing the work and getting things done. So thank you for this amazing inspiration. And I would like to finalize this interview with 2 more personal questions.
Sure.
Have you ever dreamt of or thought at some stage to do something else than humanitarian aid?
Well, I really was not planning to do humanitarian aid. So in fact, what happens here is that contrary to some of the people that I met, I do not have my plan of where I'm going to be in 20 years. I live very much on the present, and I'm very open. And each time you make a choice, there are 4 doors that closed, but 5 that are going to open in a particular direction, and then you make another choice. So it's a bit like flowing like water. So I really didn't push my evolution. I followed my evolution. So I could have done something else. It just happens that I made my choices and I'm here. But it's not like I tried to be here. No. I'm just here.
So you just happen to be here, and it just fulfilled your life.
Meaning I take one decision after the other and let's see what happens, you know. But
Okay.
I took these decisions like in full conscious, so I'm quite happy.
Okay, beautiful. And my last question would be, you know, KALU Institute has thousands of students on its Master on Humanitarian Aid and International Cooperation from all over the world. So with this 30 years of experience that you have in so many contexts, and all this wealth of knowledge, of experience, of commitment, what would be the one piece of advice you would give to our students or the other humanitarians who are watching us right now?
Okay, so there will be many ways to answer that question, but I will answer it in the following way. Each time you do something, there are 3 elements that you have to take in account, and if you take only 1 or 2 of them, what you do is imbalanced. So, and I call them in English the hands, the heart, and the head, or I would call it in French, intention, geste, contexte, meaning that in terms of the hands, right, or the geste, it means that you have to be professional. There is a technicality to apply, right? You cannot only, in the heart or the intention is that you need to have compassion and to understand. Somehow, in order to be a good professional, you need to have a compassion that leads you to indignation, and then it gives you the force to do something about it, right? And the last one, that is the head or the context, is to understand the environment in which you are. If you don't balance these 3, if you do only intention, for example, you can waste money or you can be manipulated. If you only have the context, you will be the manipulator. If you only do the gest or the hands, you're a tool. So somehow you have to balance these 3. To be a technical person is not enough. You need to understand the environment, and you need to have a philosophical and moral intention or understanding.
Wow, that's beautiful and very moving, and definitely, yes, a powerful piece of advice. Thank you so much, Jorge, for this interview. Jorge Castilla from the World Health Organization, Senior Health Advisor. Thank you so much. I think you've inspired and you've enlightened many of us with your experience and with your advice. So thank you for your time, for your energy, and see you soon.
Bye-bye.
Thank you, Jorge, for being with us from the field. I understand you are in Guinea. You're going to give us the details just now. And I've heard also you have some fever and expecting a COVID test results.
Yeah, the flight was a bit scary because there have been sandstorms in the Sahel. Therefore, there were 5 flight cancellations, and the airplane was totally full with very nervous people that were shouting. And I found the flight quite scary. So yeah, I one week after, I began to do high fever, and I'm waiting for the result of the tests.
Okay, so we'll just hope that the results are positive. But thank you for being here in these conditions with us from the field on your Sunday, which I understand is just the little moment you have available. I can see in the background you in the hotel or guest house where you're staying.
Yeah.
So that's really that's really a blessing and an inspiration to have this interview with you from the field. So tell us, what are you doing in Guinea as a senior health advisor for WHO?
So there was in 2014 a huge outbreak of Ebola in this region with 11,000 deaths. And recently, in the 13th of February, there were a number of Ebola. In this moment, there are 18 between confirmed and 14 confirmed. 4 that are suspected that are already, we cannot really know where they were, but we can assume they were positive. So let's say 18 cases. It's in a very localized area of Guinea. And I think like new therapeutics, like understanding the importance of community engagement so people participate and understand, I think we are in a much better position. And my specific role is to help them to plan operations. So I will, I am meeting with the different operational of the response, like treatment, like infection prevention and control, coordination, laboratory, logistics, and try to help them on deciding what are they going to do, what will they require to do that, how much will it cost, so we can come with a plan. And it's quite advanced. I think that for next week, we will have the strategic plan that will allow countries and partners to be aligned on one common way of proceeding. And it took some time because you need to be fast by one side, but you need to be inclusive because WHO and about Guinea is multi-country, multi-partner, and that's it.
Okay, so thank you, Jorge. So you're working directly with the national and local health authorities? Are they the direct partners you're supporting?
Yes, I also work with the countries. So Sierra Leone, Liberia, Cote d'Ivoire, Mali, Senegal, we are all working together in order to be able also to plan what are the activities that are necessary in the borders, that there are alerts that are made in the borders with confirmation and so on. Go ahead.
Wow, amazing. So are you saying that from all these countries, I mean, the ministries of health are really having this joint work together?
Yeah, absolutely. And in fact, there was a Wednesday last week, there was a virtual meeting like everything in these days among the Ministry of Health of all the countries around. And the same happens regularly between the WHO office, but we have, the countries indeed.
Excellent, excellent. And so your what is your exact role in that? I mean, you just helping people to get together, get a structure, and what is your role?
So in the way WHO has developed since 2014, when there is a new emergency, WHO responds with something called the incident management system, in which there are health operations, but they are supported by an overall manager that brings together finances, logistics, security, all these pillars of the response together. And among the functions of coordination, there is the planning, so people can, in a very systematic way, prepare and make sure that whatever is necessary will be there. That's my function, the planning.
Okay, excellent. And because then you're working on Ebola, no? So all this program is, and your mission is focused on Ebola, but then there's COVID at the same time. How do you manage both of this public health crisis?
So in fact, you have to build on it. Whatever has been done for COVID, whatever partnerships authorities have already done, must be the base of what is going to be done specifically for Ebola. And it helps already a lot.
Okay, well, that's good. And that's really, I mean, we always say it's sometimes little cliche, but there's always an opportunity in a crisis. But that's so true, actually, in the facts. You know, you have the COVID, which is a crisis. It's heavy for the country, but it enables all these mechanisms to be ready and people open to coordination and having some experience already of cross-border work. Wow, truly inspiring. So how long is this mission for you?
It's relatively short. I should be done by the 18th of March. Time everybody will have their own aligned plans. It's not so much a matter of having the plan. And you know that plans, what is important is the planning process rather than the plans, because the situation will change. But the fact of working this allow people to align. Everybody's working on points of entry. Everybody's the logistics necessary to vaccinate. You know, this is ultra cold chain, because these are vaccines like the Pfizer vaccine for COVID needs very, very low temperatures. Everybody is working on safe and dignified burials. And mainly the big lesson from the past, everybody is working on community engagement, which starts by listening. It's one of the main components, the community engagement and the listening and the local culture and anthropology and so on.
Wow, I think that's really powerful words I'm hearing from you. Like you mentioned, inclusive, cross-border work, joint work, alignment, community engagement, and I believe we could make so much use in Europe of learning from our African colleagues and counterparts on this, on how to manage a public health crisis with these elements that would probably help to enhance our response, don't you think?
Yeah, in fact, my feeling is that because there is a recurrence of certain diseases here, like yellow fever, like measles, like cholera, that people here are good on responding, because there is a recurrence, you know, so the risk is higher, but also the response is recurrent. So while for Europe, this might be a surprise of something that never happens, here there is a dynamic. And in fact, the reason why it never happens in Europe is because people have a very short memory. It has happened many times. They have been in the year 166, there was the Antonine plague and so on and so forth. So let's say that it happens, but memory is short and people forget.
Okay, so a good learning for us, nurture the memory of crisis, on how we respond and what are the lessons we learned. Excellent. Jorge, I would like to make use that the connection is still in our favor, and ask you a little more. So here you're in Ebola, and we understand very clearly what is your role as WHO Senior Health Advisor, and beyond this kind of settings, what else do you do? What else do you do in your job at WHO?
So I have been in WHO for the last 5 years. So I shifted from ECHO, where I was working as the health emergencies medical focal point at the global level, to support countries in WHO. But this support of countries has shifted during 5 years. At the beginning, I worked on creating the new program. So the incident management system that I just mentioned was the product of a joint work where we took examples, for example, on how the firemen responds to forest fires, where you need people that arrive not to be idle and not to be a hindrance. So there are a number of rules, and there is something called the incident command system, except that in the world of humanitarian, command does not work because people don't obey. So we shifted into an incident management system. And then I was one of the 3 first incident managers. So I did that part of the experience. So like the guinea pig, right? And afterwards, an interesting shift happens, because other than the new epidemic here or the cyclone there are the countries that have protracted emergencies that are old and big, like northeastern Nigeria or Yemen or this type of emergencies. So we begin to work on concentration on some countries, right? And lately, what happened when you support something for the long time? Let's imagine Burkina Faso. They had a strong deterioration already for a couple of years, but we know from experience that it's not going to end next year. It's going to take years because it's a conflict of resources or whatever. And whatever we do now will have positive or negative effects in the capacity that is local in 5 years or in 10 years. So how do you respond to a protracted crisis that is not substitution? So what I'm working now is to find the ways to be effective in the emergency, but doing so in such a way that it builds in the local capacities. and the system of supplies and health information and governance and so on. That's the type of work I'm doing now. Very interesting.
Wow, fascinating. So really building the capacity. I love when you say the no substitution, no? And I think that's been a big learning of the last years in humanitarian aid, because when you started before me, I mean, you have like 35 years of experience in public health and in areas affected by crisis. But I've seen when we started, it was a lot of doing the job for others, no? And now I like how we've learned to do also the job better, but building capacity at the same time so that people can do it. And as you were mentioning just before, they have so much experience actually.
So let's say that sometimes you need to substitute. Let's say that there is a hurricane in Mozambique that destroys everything, and then you will probably need to bring from outside a way to set up a warning and alert system for diseases and so on. So you might need, in an acute response, to substitute. But it is clear that if you substitute for more than 3 months, 1 year, 3 years, 5 years, the substitution is hard because it is going to obliterate local initiatives, right? And therefore, it is not healthy to substitute in the long term. And therefore, you need to begin to build on experience. There is nowhere where there are not excellent examples. So you can already start by a small excellent example and begin to expand using those local capacities in order to make sure that if by any circumstance you have to go, for example, for a security incident, what is left behind is better than what was there during the acute response. So there is no dependency, and that's it. Yes.
Oh, I thank you, Jorge, and yes, that's very interesting. How we still work on these phases, no? In terms of humanitarian aid, what are the phases that you choose? You say, if we substitute more than 3 months, do you have this sort of diagram in timeline in the head, or does it just come naturally based on context analysis?
So in fact, everything that has to do with the conflict probably is going to last very long time. So you must, from the very beginning, in fact, you should do it always, right? Because there will be anyhow a future. After a hurricane, there will be a reconstruction. But indeed, if you take 100 types of emergencies, you can put it on 6 blocks that are similar in terms of the need for response. So you will have, for example, everything that is hydrometeorological, in cyclone or a flood, etc. That is going to be one group, and it's of a relatively short response. You have everything that is geophysical and earthquake. That will need a huge rapid substitution. Yeah. You will have the infectious diseases that, contrary to what people believe, are a bit slower, because you know that there have been a group of people that died, but you don't really know of what, and it takes time to find out and to verify the diagnosis. Then there are the climatic, the slow drought, etc. That is very forgotten because people don't invest until they see the impact. And while these ones could be prevented, they are rarely prevented. Then there are those that are technological, human, like a nuclear accident, these type of things. And finally, there is the conflict, and have a very long-term vision of what you're going to do, which is what I'm doing in Sahel, for example, in support of the countries.
Okay, thank you so much, Jorge. I'm seeing the connection is starting to get tired. I suggest that we cut our conversation here from the field, but we're going back and we're getting back to you in 2 weeks' time. We're going to fix a time. So from your office in Geneva, that's going to give us also another angle of what is the work the work of senior health advisor at WHO, this field part and this office part.
Okay, and this is the right moment because the train is passing. It's going to make a crazy noise very soon.